Hi guys, welcome to my YouTube channel. I am Denmark Aranas, a postgraduate medical intern, and I basically provide informative videos to medical students. And also, I would like to give aspiring Filipino physicians an idea of what a medical student usually tackles in med school. If you find these videos helpful, please don't forget to hit the like button and subscribe to my channel and click the notification bell to be updated for my new videos every week. This video is part of my approach series where I discuss the proper attack to a certain chief complaint, and this is basically a guide in giving the appropriate questions to ask in the history and point out certain PE maneuvers to consider. Please take note that diagnostic examinations and management plan are not part of our discussion in this approach series. So for today, our topic is the approach to fever. Fever is a very common chief complaint in the outpatient department, and we often associate fever to infection. However, there are various other causes by which body's temperature be elevated. So here's the topic outline of this discussion. First, I would like to differentiate fever from hyperthermia. Then I will tell you the different patterns of fever. And then I would like to make you aware of an infection without fever. And after that, we will focus on the differential diagnosis for an elevated body temperature and taking into account the history and PE. Okay, let's start. Fever is defined as a body temperature greater than or equal to 37.8 degrees Celsius or 100.04 degrees Fahrenheit. Okay? While for hyperthermia, it is greater than or equal to 41 degrees Celsius or 105.8 degrees Fahrenheit. Okay, you have to remember these values so that you could be able to differentiate the two. Okay, let's define them. Fever is an elevation of body temp that exceeds the normal daily variation, and it occurs in conjunction with an increase in hypothalamic set point. Okay, while hyperthermia is an uncontrolled increase in body temperature that exceeds the body's ability to lose heat. And unlike fever, it is related to an unchanged hypothalamic set point. You have to take note that fever is more affected by intrinsic factors, okay? While hyperthermia is more uh, dependent on the environment, okay? So fever is intrinsic factors, hyperthermia is for the environment. Let's now talk about the difference of the two in terms of pathogenesis. Intrinsic substances that causes fever are termed pyrogens, okay? It came from the Greek word pyro, which means fire. So for fever, we have exogenous and endogenous pyrogens. Exogenous pyrogens are the following. It could be the microbes or the toxins produced by them, while endogenous pyrogens that are now termed as pyrogenic cytokines are the following: interleukin 1, interleukin 6, tumor necrosis factor, and ciliary neurotropic factor. Hyperthermia, like what I said, is determined more by the environment via exogenous heat exposure and also endogenous heat production. Like, for example, a work or exercise in a hot environment can produce heat faster than peripheral mechanisms can lose it. Here we have four patterns of fever: sustained, intermittent, remittent, and relapsing. In these graphs, you see in the y-axis the degrees, while On the x-axis, the days, while the dashed line represents the normal value of body temperature. Sustained fever is characterized by persistent elevation in body temperature. Then we'll go down by minimal of less than or equal to zero point 0.3 degrees Celsius, but it will not reach the normal level. Okay? This is a characteristic of lobar pneumonia. Okay? Then intermittent fever, the temperatures will go down to normal. So you can see it touches the dashed line. And this is characteristic of malaria. Remittent fever, the temperature will go down, but it will not go down to normal. And there is an escalating temperature, and there is no normalcy. This is a characteristic of typhoid fever or salmonella. And this is termed as a step ladder pattern. Okay? Typhoid fever, step ladder pattern. And then relapsing, there would be febrile episodes followed by a febrile episodes and then a sudden occurrence of fever. Okay? So there is a period where you do not have fever. This is a characteristic of malignancy. The Hodgkin's lymphoma, it is called the Pellebsten fever. Okay? So remember, for sustained, this is characteristic of lumbar pneumonia, intermittent, malaria, remittent, typhoid fever, relapsing is for malignancy, Hodgkin's lymphoma. Here we have the different types of intermittent fever. Quotidian, which means every day. So there is daily fever. This is commonly seen in Plasmodium falciparum and Plasmodium knowlesi. And then tertian, fever every 3 days for Plasmodium vivax and Plasmodium ovale. And then quartan, fever every 4 days, commonly seen in Plasmodium malariae. Okay? So you see, it is very important that you know these patterns of fever to know the most likely diagnosis for the condition. But is it possible to have an infection without fever? Well, actually, yes. As early as now, you should be aware that newborns, elderly, patients with chronic hepatic or renal failure, patients taking glucocorticoids, and patients treated with anti-cytokine may have an active infection in the absence of fever because all of them have a blunted febrile response. Okay? Remember that. For example, an elderly male comes to you due to 2 weeks cough. However, the patient is afebrile. Despite that, he is still considered to be infected, even without fever. Because upon further investigation, you will see in the x-ray that there will be lobar consolidation. So that is lobar pneumonia. We said a while ago that the pattern of fever for it is sustained fever. However, that would not be the presentation in an elderly male. And that elderly male would be considered as low risk community acquired pneumonia. So it is very common to see an elderly with pneumonia without fever. That is why we have to be more aggressive to this set of patients who would present as afebrile even if they are severely infected. We do more lab tests to determine the real picture of the patient if there is an ongoing infection. Medical students, please advise your grandparents to seek consultation from a doctor whenever they are experiencing chronic cough and convince them that even though they are afebrile, they should still always consider them having an infection. Okay, please remember that. Let's now talk about the various differential diagnoses, starting with hyperthermia. So we have four, the heat stroke, neuroleptic malignant syndrome, serotonin syndrome, and malignant hyperthermia. So what is heat stroke? This may result from central nervous system dysfunction or excessive physical exertion in a hot environment. Like what our frontliners in the military do, they are very prone to heat stroke with strenuous activity plus intense heat in the field where they work. The mortality rate is very high. It is 10%. And the vulnerable ones are the elderly patients with arrhythmias or problems with the rhythm of the heart and those who had an episode of heart attack before. So for our military, please take note of these signs and symptoms that serve as red flags of heat stroke, from fainting or dizzy feeling, cold or pale clammy skin, excessive sweating, rapid weak pulse, nausea or vomiting, and muscle cramps. From heat exhaustion, it will go to the extreme end of heat stroke, where the patient will first experience throbbing headache and then dizziness and confusion. You would see them having a red, hot, dry skin. There would be no sweating, still with rapid, strong pulse, and the body temp would be elevated with nausea and vomiting. And lastly, they may lose consciousness. Okay? So it is important to take immediate action to cool the person. How so? By loosening their clothes, getting to a cooler environment with air-conditioned place, and sip of water if they are conscious, and then you may take his he or she in with a cool shower or cold compress. Okay, remember heat stroke. Next is the neuroleptic malignant syndrome. This is associated with intake of antipsychotic drugs 2 to 10 days. As you can see, the patient will usually manifest with elevated vital signs here, and the most prominent would be hyperthermia, and NMS has a tetrad. It includes altered mental status, rigidity, elevated temperature, and autonomic instability. So, it is very, very important to note any drug intake of a patient. And the closest differential would be serotonin syndrome, wherein there is serious drug reaction due to too much of the chemical serotonin in the brain. Okay? Drugs implicated in this are antidepressants, opioids and pain meds, cough and cold drugs with dextromethorphan, street drugs like ecstasy, natural drugs can cause it too, and drugs for treatment of Parkinson's disease like selegiline. Symptoms usually manifest from an hour to 1 day upon intake of the drug. So for patients with an elevated body temperature, it is very important to do a drug intake history. As for malignant hyperthermia, this is triggered after administration of anesthetics, okay? And most especially halothane. This causes hypermetabolism and build-up of lactic acid. This is given with dantrolene as an antidote. However, the best initial treatment really to all of these drug or medication-related diseases is the withdrawal of the offending substance. Now we move on to the differential diagnosis of fever. So we have here four primary categories: infectious, malignant, inflammatory, and miscellaneous causes. As for infectious, there are so many etiologies to consider. It could be either from bacterial, viral, parasitic, fungal, and rickettsial. We will not be going through each because this will be discussed further in detail in your microbiology class. Suffice for you to know that infection is characterized by the presence of fever. However, like what I explained a while ago, infection without fever is still possible, especially among the elderly. Okay, remember that. As for malignancy, the most common disease related to having fever are the following: Hodgkin and non-Hodgkin lymphoma, leukemia, and renal cell carcinoma. All of them has a dysregulated cytokines manifesting commonly as fever. Next, we have inflammatory. Inflammatory processes such as pericarditis, trauma, stroke, and routine immunizations induce the production of interleukin-1, tumor necrosis factor, and or interleukin-6. Could be individual or in combination. These cytokines trigger the hypothalamus to raise the set point to febrile levels. And among it all, an autoimmune disease, the systemic lupus erythematosus, is also most commonly associated with fever. As for miscellaneous, we have three: the drug-induced fever, factitious fever, and fever of unknown origin. Factitious is also known as imaginary fever. It is just a subjective complaint of the patient that upon physical examination, there is actually no fever. As for drug fever, it is related to an intake of medication. And the most common drugs implicated in drug-induced fever are the following: the antimicrobials, especially piperacillin tazobactam, anticonvulsants, antiarrhythmic agents, and or other cardiac agents. You have to take note that the fever appears 7 to 10 days after the initiation of the drug. So always ask about any intake of drugs by the patient with fever. Next is fever of unknown origin. This is a diagnosis of exclusion or a wastebasket diagnosis, wherein you have ruled out all the possible etiologic cause and could still not find any clear cause. Presented here is the criteria for diagnosis, and the most commonly associated causation of infection with fever of unknown origin is TB, okay? Followed by malignancy caused by non-Hodgkin or Hodgkin's lymphoma, and then inflammatory etiology, the rheumatoid disease, miscellaneous drug-induced fever, and there's still a fraction of patients with an unknown etiology, 9%. As for physical exam, we need to do a comprehensive head-to-toe assessment of the patient with the objective of determining the point of infection or inflammation and even malignancy in the patient. From general survey of the patient, we could note for rashes and think of viral infections like measles and chickenpox. Observe the eyes if it is ecteric, which could indicate liver involvement. And upon inspection of the throat, a common problem would be tonsillitis. For the skeletal system, we can take note of possible open reduction in internal fixation related infection for fractured bones and even bone cancer. For muscular system, certain infections like tetanus and botulinum would cause changes in muscle tone. It could be spastic or flaccid, respectively seen in tetanus and botulinum. For circulatory system, you could check the patient's blood pressure and pulse rate Both would be increased in cases of infection. For digestive system, by palpating a quadrant of the abdomen, we could locate and identify the point of infection or inflammation. Like for appendicitis, we could palpate that at the right lower quadrant and then do certain maneuvers for appendiceal signs such as Robsing sign, Sowa sign, heel jarring, and note for rebound tenderness and even guarding. For urinary system, we could do costovertebral angle tenderness checking by doing a kidney punch, which would indicate an acute pyelonephritis. For the nervous system, we could assess for meningeal signs of meningitis. We could do Budzinski and Kernig sign. For reproductive system, by just doing an inspection for discharge, we could already suspect for sexually transmitted infection. For women, we could still do speculum exam and bimanual examination. For the lymphatic system, we do palpation and take note for palpable and tender lymph nodes. For endocrine system, we do palpation and take note for thyroid enlargement and tenderness. Associated findings could be tremors and tachycardia, which would indicate hyperthyroidism. For respiratory system, we auscultate for crackles as an important sign of pneumonia. These are just a few things we could do in the physical exam of a patient. What I would just like to stress here is that we have to do a comprehensive head to toe PE to all patients with fever to pinpoint the source of infection, inflammation, or malignancy. Well, that's it. I would like to end my presentation with a quote from the Bible from Romans chapter 12, verses 11 to 12. Never be lacking in zeal, but keep your spiritual fervor, serving the Lord. Be joyful in hope, patient in affliction, and faithful in prayer. As medical students, you must maintain your great energy or enthusiasm in pursuing your dream of being a medical doctor. You must have the passion for service in the name of our Lord Jesus Christ, joyfully hoping that someday you may be able to help in giving out His healing grace. You must always be patient in your journey to that MD because for sure there will be a lot of trials along the way. And in order to survive it all, you must remain faithful in your prayers that whatever you are and will be facing is part of the process of molding you into the best physician you can be someday in God's will and time. Thank you for listening. Have a good day.